Morning, Dr. Khanna.
Yeah,
I
good
can see
morning.
you on the screen. This is Ajit from Jakarta, and we have a very good panel, and I'd like to uh, welcome Dr. Jeffrey Adipranatu from Surabaya, my panelists, Dr. Mee Lestari, Rini Pramesti, Mohammad Yusuf Al-Safag, Abdullah Hakim, Tegu Ponomo, and Dr. Tegu Santoso here. And welcome, Hannah, and let's hear what you have for today.
Okay, so we have a very interesting case, and let us see whether we will be able to finish it in time. So this is a case, this lady presented to us a few days back with an acute MI, and she underwent a primary angioplasty, but her creatinine was 3.3 at that time. And then we actually did the angioplasty to the LED, and this patient also had a very tight and tortuous diagonal, which was almost like a 99% CTO of diagonal. And so we sort of deferred the procedure for diagonal, and the nephrologists were involved. She was put on N-acetylcysteine, and over a few days, her creatinine has stabilized to normal now. Can you go next?
Next slide.
And what we see on the angio, which I'll be showing you right now, so we have a left main, which is about 20-30%, and we have a LED, which again ostial LED, which is 20-30%, and there is a very tight high-grade stenosis of the mid LED, and there is a very tortuous diagonal, which sort of originates from the proximal LED. It's a large size diagonal, and it's almost like a CTO. So the go next.
Next angio.
So here, if you can appreciate the tortuosity of the diagonal ostium and the high-grade stenosis. So our plan now is to wire this diagonal and then put in a stent, maybe do a bifurcation stenting. We have done the OCT and FFR of the LED, and the plan is to put a supraflex screws in the diagonal, and then maybe to crush and do a bifurcation stenting, or the first step would be to just do a cutting balloon and see if the results are good. We can even stop it by doing a drug coated balloon angioplasty of the diagonal ostium. But if there is a plaque shift in the LED, or if there is a bad dissection or a stent protrusion, strut protrusion in the LED, then we will go ahead and do a classical crush and a bifurcation stenting. So I'm going to now take you through what we did for the LED angioplasty. Go next for the
Angioplasty, please.
So this is the lesion. We crossed with a
Next.
all-star wire. Go next. Is it in one loop?
Next. 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 Next.
Why is it not playing? Ask him to show the final one. So this is the angioplasty in progress. So I'm going to be go next.
Next.
Let one person see. Go next. Show me the final shot here, because there's no point. Next. So our plan, while we are seeing the angioplasty, the plan today was to put a supraflex screws, because this stent has very unique properties. It is the thinnest possible strut which is available in the market, right from a size from 2.25 to 4 millimeter. And as you have heard Dr. Santosho, that it has undergone a big trial, a head-to-head comparison with Zynes. And it is a non-inferiority trial where it has been proven to have an equal efficacy and safety. This also has such small struts, and the polymer, biodegradable polymer, which sort of elutes drug and degrades within 48 days. It requires shorter DAPT intuitively, but it's not been proved. And because of the thinner struts, the risk of restenosis is much lower, the inflammation is much lower. And it is excellent for tortuous anatomies because of the the way it is made, and there is a valley-to-valley connection, and it is the stent can actually take a very tortuous anatomy, and that is the reason we thought we are going to be using this in this case. So this was the final result which we had achieved after the angioplasty. So today we have done the FFR because we wanted to assess the left main stenosis and also the ostial LAD stenosis, and also to see our apposition of the stent which we did the other day. So I have Mr. Farzan with me who would be discussing the OCT. The FFR here was 0.95 after the angioplasty, and so there is the proximal LAD or ostial LAD and distal left main disease is not significant, and we are not going to be handling that. Over to Mr. Farzan.
Yeah. Hello, everyone. So we have done.
Can you hear Mr. Farzan?
Hello.
We can hear.
Okay. Can you see the OCT image?
No, we can't. Can you show us the OCT pictures, Khanna?
Can somebody focus on the OCT? Okay, so you got it.
So hello. So we have done this OCT of the LAD which was stented previously, and so there are some blood swirls, though we have been able to see the straight apposition distally as well as proximally throughout the vessel. So right now we are at the distal edge of the stented segment, and we see that these struts are opposed, and there is no distal edge dissection as well. And as we move proximally from the distal segment, we see that the area in the middle of the stented segment is 4.9 mm square, and if we keep on moving proximally, we see that all these struts are well opposed. So there is no malapposition and there is no edge dissection at the distal edge. Proximally as well, so we are moving proximally, and we see here that proximally as well there is no malapposition and there is no edge dissection either. Going to the proximal non-stented segment of the LAD, we see that there is an area of 9.8 mm square, and in the left main also we have this area of 16 mm square, and it has been further confirmed by the FFR which has been done that this is a non-significant lesion, and therefore it is not being stented today. Thank you.
Okay.
Now, can I go to the runs of today? Can you just show the first and don't pull on this. Somebody's pulling on this. Okay. So this is the RAO-caudal view. Here you can appreciate, although it looks like there is a tract and it should be an easy one, but this tract actually is very tortuous. And if you see this LAO-caudal view, it's almost like a S. If at all there is a channel, it is a reverse channel, like a U-shaped, reverse U-shaped channel, which we need to cross and then dilate and put in do a cutting balloon and see if the results are not too good, then put in a stent, or if there is a plaque shift in the LAD. So we have put a wire in the main LAD, and we have taken a whisper wire with a curve which is almost like more than 90 degrees, and we want to just see whether we can wire this diagonal and then go ahead with our procedure. So at this stage I would like to have your suggestions and go ahead with the case. So we are now going with the whisper wire. We have put and trying to go into that diagonal. Okay.
So can I just take the opinion of the panel of how they would tackle this complex diagonal? So Jeffrey, what would you do in this sort of, what would be your hardware you would use to try to get into this diagonal?
That's why we use this.
I'm not sure whether the first stent was covering the ostium of the diagonal. Is that covering the diagonal ostium or not?
The question, Khanna, is the first stent covering the diagonal origin?
No, it isn't. Can you go back on the angio? Okay, let me take an epicranial and show you. Just go to the epicranial. Epicranial, Shyam. Okay, areocranial and aleocaudal. So this is the epicranial. It is just beyond the first the origin of that diagonal aleocaudal.
Well, in that case, I just try to cross the lesion with a wire and pre-dye first.
Can I have more of audio here?
Can I have also comments of the panel, Dr. Santos?
Dr. Santos,
Yes, Dr. Khanna, it's a very nice demonstration. We learn a lot from you. Just want to tell the audience here, my usual practice, if you are dealing with patients with chronic kidney disease, patient is diabetic, patient has a very high blood urea level, 190 something, and creatinine also very high. I have no idea about the CCT or eGFR. Must be patient must be in at least chronic kidney disease stage 4 or probably stage 5. If the patient start on dialysis, my usual approach is to do the so-called zero contrast or ultra low contrast PCI. That means by ultra low, I means the use of contrast volume is the ratio of contrast volume versus calculated creatinine clearance is less than 1. With this, we can prevent contrast-induced nephropathy. And I cannot describe this too much here because of time limitations, but for those who are here in the audience who are interested in about this zero or ultra low contrast nephropathy, I deliver a talk at around 7 o'clock this evening. And the other thing is that even in cases like this, we can use OCT without contrast. And I can describe the technique here more in depth at 7 o'clock this evening. And it is very useful to prevent contrast-induced nephropathy because we know contrast-induced nephropathy is ominous. Contrast-induced and even patients with chronic kidney disease, especially patients diabetic, if we do stenting, it is always associated with a high rate of TLR, myocardial infarction, and complications like stent thrombosis and so on. So if we have contrast-induced nephropathy on top of chronic kidney disease, this is always ominous. This is always associated with much higher long-term mortality. So I think this is just my common practice.
So
Yeah, I would actually totally agree with you because what we plan here to do, I mean, when we have to do OCT on these patients, normally we are using either dextran, we use tetra starch, which is 6%, or we use dextran, and like in this case, so here we actually can get a good image, as well as we are not giving enough contrast while doing the doing the OCT. So that is definitely a very good strategy, that OCT can be done without contrast, and I would, if I was there, I would have loved to hear what is the technique of Dr. Santoso to actually do OCTs without contrast. And but what we use here is we use dextran, or we use 6% tetraban. So now the strategy here, I think we have advanced our wire into, we are trying to get this wire into this tortuous diagonal. Let me see where we are. I think we are through, but I'm just going to take a small cine. And we have sort of mixed contrast, 50-50 contrast. It is a Visipec contrast mixed with 50% saline, so equal volumes. And that's how we are conserving the contrast volume here. So I think we could wire this diagonal, and now we are going to advance this wire. Just 1 second. I thought it would just go back on the table. I thought it would be very difficult to wire this, but looks like we have been lucky today. Okay, can I go to a cranial view or something? So sometimes these slippery wires with a good bend more than 90 degrees actually works better. So now we are in the diagonal with the whisper wire, and I would take a balloon to dilate it, and maybe a cutting balloon if I can get through. Can I have a 2.25 cutting balloon?
Khanna, would you first pre-dilate with a small balloon and then try to get a cutting?
Maybe I think that's a better strategy because the lesion is too tight. Can you just give me a 2 millimeter normal balloon? No, 2 millimeter. So that the cutting balloon is a bulky balloon and may not go there and actually create more problems.
Okay, any other comments from our panel, esteemed panel, if they would like to comment on procedure?
Mr. Dr. Khanna, this is May. From spider view, we show that the first diagonal is very tight, ostial. And after, what your plan technique for stent implantation for the ostial first diagonal?
My technique here would be to first go and dilate with the balloon and then do a cutting balloon, and then see if I can get a good result with a cutting balloon. I may just do a drug-eluting, drug-coated balloon and assess the result. If the result is good, we may just stop there. But if there is a plaque shift in the LED, or if the result is there is a lot of recoil or a dissection, then in that case I have to stent, and then we will go ahead with the bifurcation stenting. So I definitely would like to, Ajit, what would your view be on this? How would you approach this lesion per se as a de novo lesion, and then if you get into problems, what are you going to do?
Yeah, well, I agree with your strategy, but it's very unlikely that you will get a good result
With
or a cutting balloon at the end of the procedure with this sort of tortuosity. And I think, Khanna, you may be committed then to a bifurcation stent.
yeah, that is my plan too. And for these sort of tortuosities, what what wires would you use? I chose a whisper. What would you choose? And
Yeah, I would completely agree. Hydrophilic wire, which has a lot of talkability with a nice curve, would be
Double
what I would
Meckel.
use.
बताना
Any other
balloon.
comments, from the panel?
Stand बताना कहाँ है?
No, not comes. Yes, at the guiding.
Okay.
Yes, sir, into the diagonal.
What kind of balloon is this, Dr. Khanna?
This is a 2 millimeter. Which balloon is this? Which balloon is this? This is a 2 millimeter balloon from Boston Scientific, and we'll start dilatation from here. This is not a cutting balloon. Okay, go up. Get me a cutting balloon after this, 2.25. Go up.
4,
6, 8, 10,
10.
12. Deflate. Not this, that. Okay, go up. 2, 3, 4, 5, 6, 8, 10.
10.
Okay, deflate. Give me a 2.25, or maybe 2.5 also is okay. 2.5.
2.5.
This was 2, no?
This was 2.
2.25. 2.
If you end up
Cutting.
Khanna, with the bifurcation stenting, what sort of technique are you going to do for this? Sort of
I mean, normally I would probably put a stent in the diagonal, and there will be some struts protruding in the LED. We'll crush that, then put a crush that and put a LED stand and then do a bifurcation kissing balloon. That would be my
So
strategy for this
cutting balloon, sir.
cutting balloon.
2.25 cutting balloon.
And we unfortunately had a loss of time for the transmission, so we have about 5 minutes. So
Okay, so let me just
take
be
your
fast,
time. Please take your time, but it's just for your information.
Okay. So we have dilated with a 2 millimeter balloon, and now we have taken a 2.25 millimeter cutting balloon. This is 2.25.
2.5. 10.
Okay, hold. Holding.
Holding.
How often do you use the strategy of cutting balloon followed by a DEB, Khanna, in your bifurcation strategy?
When I am doing, provisional stenting, many a times, when we just do a cutting balloon and a DEB and then stent, at least 5 to 10% of my cases would have this strategy. I think we pulled the wire.
LED wire is what?
No, okay.
So this is a sculpt or a cutting balloon?
This is a cutting balloon from Boston Scientific. It's not an angiosculpt.
I would like to ask the panel about this strategy. Who is for just do it simple by pre-dilating the lesion and then stent it?
Or give like the drug cutting balloon after the cutting balloon? What about this?
आगे कर रहा हूँ थोड़ा.
So I think in general, the option of a cutting balloon is always there, but I think that at the bifurcation, if you can get away without a stent, it would be great, but most often you land up with a poor result and you're committed to put a stent then. So I think this is the issue, and with a normal balloon, unfortunately, there's more dissection than a cutting balloon. But once you've done a normal balloon and then do a cutting balloon, maybe the advantage of a cutting balloon is really large.
No.
Yeah, that is true, because I would have probably done that, a direct cutting balloon, but we used a very low, just a 2 millimeter at a low pressure. So we are with the cutting balloon 2.25 and starting from the ostium of the diagonal, we have tried to sort of spare as much of LED as possible, and then we'll be sort of there for about 10-15 seconds, and then maximum कितना है?
It's 12, sir. 12 is 2.4. Rated RBP.
So Ajit, in your practice, how long do you inflate this cutting balloon? Do you just dilate and leave it come back, or you are there for some time, 30 seconds or 15 seconds?
So I would exactly do what you're doing now, go up slowly, hold it there for some time, come down slowly, because the importance is to remodel the vessel with the cuts.
Correct.
Nicely, if you want to get away. I don't think a hurry would help.
Correct.
in this.
Otherwise the advantage is lost.
So, Khanna, can you still hear me?
Yeah, I can.
It's just a minute left, so I'm
Okay.
sorry we're having you, but
I'm
it's
sorry
just that-
because this case was actually, we didn't realize the tortuosity, and there were some problems with the transmission and hookups here, so that's why we started a little late. although we
So
were
but,
here at 5:30 in the morning.
You take your time and do the case, and that's important, really. So if I can just sort of summarize the case, and in the last few seconds of this live transmission, it's a difficult case where you saw a diagonal bifurcation following a PCI to the LAD in a primary scenario with CKD. The issues were to check whether the stent previously deployed was good. The OCT pictures, obviously, with the worry of contrast in a CKD patient, had to be done carefully. So you can use Dextran or half. You can dilute your contrast and use it with OCT. And the next issue is the technical issue of the acute diagonal, which rises up from the LAD, and how you wire it, and what is the strategy, which includes a cutting balloon and a provisional stenting if required with a very trackable stent like the Superflex. So if there are any comments from my co-chair and my panel, then maybe we can finish off with Dr. Jeffrey's comments, please.
Yeah, I think this is a quite challenging angulation of the big diagonal, and I think it was wired nicely, but if you do not succeed with just doing wiring like this, you might consider to use the crusade because the angle is almost 90 degrees. But I'm a simple man. I would like to do just pre-dilatation and then try to stent it instead of using a cutting balloon.
So
because sometimes cutting balloon is quite bulky, and sometimes you will stuck there and not able to advance in that 90 degrees angulation of the ostium of the diagonal.
So Khanna, your final comments?
okay, so this is what we have got after the cutting balloon. So there is a recoil at the ostium, and this diagonal seems to be big. My only concern is whether we leave it like this, or we go ahead and stent, do a bifurcation stenting, and at the cost of LED, because the LED is pretty clean. We did a OCT and there is no plug there.
So Khanna, I think thank you very much for a lovely transmission in the time that you had. Please give him a big hand. And if you want to show your result, maybe an hour later, you can come back and give us a result.
That will be wonderful. Okay.
Yeah, thank you.
Thank you.